Good morning, everyone, and welcome to the first virtual training on HIV self-testing in the Caribbean. As you are all aware, the implementation of HIV self-testing has been discussed and debated considerably in the region over the last couple of years. And as PAHO, we are pleased to be collaborating with PANCAP Secretariat for the implementation of this training. We trust that this training will help to guide the region in a positive direction as we go forward and look at the possible implementation of HIV self-testing in the region. Before we go to the short agenda that is planned for today within the whole context of this training, I have two housekeeping announcements. First, your mics are muted. If you have questions as the presentation progress, please type and submit these in the question field on your webinar panel. We will address them during the question and answer segment at the end of the presentation. Secondly, we are recording the webinar and we will share the recording on PANCAP website and social media platform for the benefit of persons who could not have attended this live session. My name is Sandra Jones. I'm the technical advisor for HIV-STI with the Pan American Health Organization Caribbean Office, which is based in Barbados. I now take this opportunity to hand over to Dr. Shanti Singh, who will be making very short remarks on behalf of PANCAP. Shanti, over to you.
Thank you very much, Sandra. Good day, everyone. I take this opportunity to welcome you on behalf of my director, Dr. Rosamond Adams, the director of PANCAP, to, as Sandra mentioned, one of several trainings that is really aimed at building capacity around HIV self-testing. We're very pleased about this initiative, and I wish to upfront thank PAHO, CVC, COIN, and all of our partners for collaborating with us. Thanks in advance to our presenters. I assure our participants today that your learning will be significant. You will then have the opportunity to decide how to advance HIV self-testing in your programs, but we do look forward eagerly to seeing some countries taking self-testing on board. As you would know, UNAIDS in its 2020 report for 2019 shows that 77% of people living with HIV know their status in the Caribbean, or 254,000 persons. When we take a closer look at what is happening in our countries, we see that 2 countries in the region have achieved the first 90. Several countries are almost there and need to keep the momentum. At the same time, however, we have countries that have been reporting lower achievement, and in fact, many of our countries have not reported on the first 90 to the most recent GAM reporting process. When we take this entire picture into consideration, we see that the testing gap stands at 43,000. It is a significant gap, but we believe that it's achievable. I think what is not clear is the degree to which the key and vulnerable populations are accessing HIV testing. As you would know, we've made progress, but there continues to be significant stigma attached to HIV, and certainly key populations face double stigma. Making accessible HIV self-testing, therefore, is making accessible, in my mind, an additional tool for persons to know their HIV status. The evidence in support of HIV self-testing is robust. I am sure our presenter will share some of this with you today. Again, we have done well with HIV testing, but more needs to be done. We have to ensure that we take on board all innovations, such as this one, HIV self-testing, and make those innovations available to those people who need them. And so I wish to, again, on behalf of Dr. Rosamond Adams, the PANCAP Director, say thanks to PAHO, CVC, COIN for this collaboration, and I look forward to today's session. Thank you, Sandra.
Thank you very much, Dr. Singh. Just a quick background before we go directly into the training. In 2019, WHO released a new testing guidelines for a changing epidemic. A major recommendation was the use of HIV self-testing as an approach to HIV testing services. The guideline, which is an extension of what was developed in 2016, WHO recommended within the guideline HIV self-test as safe, accurate, and effective way to reach specific populations for which there is a need to scale up testing. Globally, we see countries are advancing with HIV self-testing and are developing self-testing policies as they advance with the strategy. In the Caribbean, the use of HIV self-testing has been discussed, as I mentioned earlier, with little advancement. The Caribbean Multi-Project, Multi-Country Global Fund grant through PANCAP, CVC, COIN. The consortium included HIV self-testing with the overall aim of expanding access and to improve HIV testing uptake and linkage to care, and also as an additional approach to overcome barriers to diagnose those with HIV infections and as an opportunity to unlock and advance the first 90-90 in the Caribbean, which Dr. Singh just spoke about. PAHO is the implementing agency for PANCAP for this component of the Global Fund project. And PAHO is providing overall technical guidance and support for the implementation of key high-impact evidence-based intervention in the regions for which HIV testing is one of those interventions that were identified. HIV testing is one of the first training that we are embarked on. And as I mentioned earlier, we're very happy that you have been able to join, and we look forward to the advancement of HIV self-testing as part of the national strategy going forward. I would not take any more time from the presenter because I know she has prepared a detailed presentation which includes critical information for us in the region. Since I've now sufficiently provided the background to this training, I will now hand over to my colleague from WHO, Cheryl Johnson, who will be facilitating the virtual training this morning. Just before I hand over to her, I just want to add that Dr. Johnson is a technical officer with WHO in the area of HIV testing services. Dr. Johnson, I hand over to you.
Well, thank you so much, everyone, and welcome to the training. I'm so glad to be with you today to talk a little bit about HIV self-testing and orient you to, I think, which will be a really in-depth training covering lots of details in the coming discussions. So I'm glad to be kicking this off. So I want to maybe start, there's already been a little bit of this discussion around the epidemic and the testing situation. And I think it's really important before we talk about self-testing to take a testing lens to our epidemic and to the data we have, because that is the background in which self-testing needs to be thought through for implementation considerations, for strategic planning and thinking. So I'll spend a little bit of time on that. And then I want to walk through with you just some of the strategy and considerations, you know, the kind of key evidence, some of the latest information about the products in the market, as well as some future considerations, you know, really speaking to a lot of the things we're learning in real time on the use of self-testing in the context of COVID, which might be really applicable to things folks on the line are dealing with. And I will maybe open it up then for some questions at the end. And one other kind of piece that we wanted to highlight to you all is that while the training is taking place today, there are lots of resources available. And I also would really direct you to our WHO HTS info app. And I'll talk a little bit about that, but that's something you can really download on your phones, on your tablets, to access the latest guidelines and information. And just these 5 resources to kind of give you a little bit of background are, some very brief videos, and then 2 systematic reviews and the latest policy brief that Shanti had just was referring to. So really, these might be useful things to orient yourself to if you're looking for a little bit more detailed information or some additional resources that can complement the training slides. So to kind of move into the progress to the global targets and take a testing lens to where we are in the HIV epidemic and what's next, I think it's helpful to know where we've come from. So I think especially in the Caribbean and a lot of the countries on the line today probably know this quite well, how testing, it was a slow start. There's been significant progress, but as we get closer and closer to our targets, even though we're procuring a large number of tests in some settings, we're still missing a significant number of people with HIV who don't know their status. And it's really challenging to think through, what these extra approaches, what innovations we need to bring to our programs that will really help us stay on track, so then we can really scale up testing in an efficient and effective way to place as many people as we can on treatment, but also contribute to the larger prevention programs. And I think especially when we think of the region we're in today, we're talking about a key populations driven epidemic in context where we really are thinking through how we can focus and ensure we also then have that good link to care and viral suppression. And particularly here, key populations being so critical as the largest proportion of new infections, to 62% now in the latest global report, and 76% of new infections in Latin America and the Caribbean were among key populations and their partners. So really thinking through how to reach these populations through testing services is one of the key challenges that we're facing and thinking through, and why we're really thinking self-testing may have a lot of value is how well it can potentially reach these additional populations. So for us, when we're thinking about the gap, we've got kind of a roadmap of, yes, we're talking about reaching the first 90 or really the first 95 now about the populations missed. And I think another population we're really talking about in addition to key populations are partners of people with HIV. I know there's lots of programs maybe on the line thinking about social network or index testing approaches. So you might be kind of thinking of how to use self-testing in that context, which is great. STI patients or settings where you might have a high-risk group, but you don't necessarily always have testing services available. So you might be thinking about that. And increasingly, we're also seeing in a lot of the data we look at that there's people with HIV who might have been lost to follow-up. So folks that never started treatment that need to potentially test to start treatment or need to be relinked and brought back into care and might be looking to something like a self-test or testing services as a way back in to services and care. And so I think we do have a lot of challenges ahead with testing, both in terms of the absolute numbers and relative gaps between groups. And it's important for us to think of, what are these strategic ways to reach the populations, which may vary widely depending on the countries and the context. So self-testing, I think, is a great thing to be talking about for the Caribbean because it is something that is really client-centered in its approach. So I'll now kind of start to walk through a little bit of the kind of testing background and service delivery. So these are some of the guidelines that we have available, which I'd really encourage checking out if you're looking for some additional resources. And the app, which I mentioned, is a really great resource, especially if you are looking for the latest 2019 guidelines. You need the list of recommendations, anything on self-testing. There's interactive testing algorithms and a great search function as well. If you just want to search things like self-testing, you can even favorite and then share things with your colleagues or other folks that you work with from the app. So this can be a really helpful tool when you're just trying to learn, especially for me, I always use it when I'm in the field or kind of away from my hard copy of guidelines. So maybe this is something to also explore a little bit more with you towards the end of the presentation if there's questions. So I think the guiding principles for testing, are really the same for self-testing. So, WHO has maintained these 5 C's when it comes to testing services. And people often ask, well, how do these change potentially if you introduce something like self-testing? But they really are the same. Self-testing for us at WHO and for programs, it's so important to ensure that self-tests are distributed to people who want to test themselves or that are of the age of consent in your country. It's really important to think about if you're doing a secondary distribution or a partner delivered type model, that you're really thinking through that approach of how this is going to be safely implemented with the communities and ensuring that. The confidentiality as well. So the way in which kits are distributed or accessible, it's important to provide options that can be really helpful to maintain confidentiality. A lot of people turn to something like self-testing because of concerns about confidentiality. So that can be a really great kind of way of making it appealing. For counseling, WHO, we really recommend pre-test information and then post-test messages, which can be really delivered at the site of confirmation. So when someone picks up a self-test or gets messaging through a video, different types of materials, instructions for use, community worker. There can be lots of ways to get pre-test information when kits are distributed. And then the counseling service can really be available for in-depth if somebody is having a reactive self-test and then needs to get further counseling, et cetera. Additional support tools for that I'll touch on a little bit more, but this guidance really does stay the same. And then for us, we'll always recommend, correct results, ensuring that products are accessible and our quality products that are accessible is so important. So I'll talk a little bit about the pre-qualified products that we have at WHO, but something to be thinking about. And then as always, with any testing, having kind of the linkage structures and support, so critical. So I think these testing principles, while designed for traditional testing programs, have the same relevance for something like self-testing and are always good to keep in the back of your mind if you're thinking about self-testing and how you'll make sure you're maintaining the 5 C's or adapting to the 5 C's for your program. The other kind of backbone, I think, to self-testing programs, are the critical enablers and things like task sharing. So critical enablers, really are these kind of background structural policies and support systems like having the right laws and practices, empowering the community, reducing stigma and discrimination, preventing violence. So I think even at the introduction of this program and the training today, you might be in a setting where key populations are double stigmatized. So when thinking through the planning, the implementation of something like self-testing, it's important to ensure that folks are going to be protected, have the right access to services, that they can get confirmatory testing, that they can get treatment. Things like the community empowerment piece can be so important. And we've got a lot of experience now with something like self-testing that it can even be a tool of building up empowerment in communities where folks who didn't have access now have greater access or are linked into health services. So I think that's a central piece to the conversation, as well as task sharing, which is something we've kind of recommended about lay providers, because when it comes to distributing self-test kits or how they're implemented, the community lay providers are going to be so critical. Key population-led service delivery being another key target that we're all working towards in the HIV response is something to then think about as well, of how your existing task sharing systems may benefit from the additional intervention of self-testing, or how you might then use self-testing to potentially broaden things like task sharing initiatives across different aspects of your response. And then I think the other kind of key framing, across all testing services, but really important to think through for self-testing here is the three key pieces. So when we talk about testing services, whether it be self-testing or any approach, we're really talking about kind of three kind of components that you put together. So the first being, how are you mobilizing and creating demand for the right population to get access to testing? So if it's, men who have sex with men, or a certain geography, or people with STIs, or wherever your testing gap is, how will you mobilize and create demand for testing? Then the second being, well, how then do we actually deliver the testing services? And then the last being linkage to post-test services, so that folks who get into testing services are really getting a meaningful referral and getting linked to something like prevention, PrEP perhaps, or something where if they have a reactive test, that they're really getting that confirmation and then linked to treatment. And when we're designing these approaches, you might be thinking through a different mobilization or a different linkage service depending on the population. And you might also be thinking about when, where, who, and what. So, is this service going to be something you do all the time? Will it be something that's maybe intermittent, or, every once a year perhaps, depending on the setting? Is it something you might want to change the way in which you the time of day you offer it? So maybe you are doing midnight clinics or outreach to key populations at a time that's convenient for them. And thinking through, like, what's that package of service delivery? So who's delivering it and what goes along with the testing services to really make it appealing. So I think there's a lot of considerations when thinking through how to implement self-testing. And all of it really comes down to, who's that testing population that you're missing, and how will the self-testing, the additional offer of self-testing, help you reach and then link that population to prevention or treatment. And here's just kind of a summary that we've used in our global guidance to think through testing more broadly, but this is a very simple framework for thinking through, well, how might you take your, facility-based or self-testing and community models, partners or couples-based testing services, and either introduce something like self-testing or take a more focused strategy towards it. So you might be thinking, I'm going to focus on hotspots, or I'm going to focus on a certain type of client or a certain type of clinic, and that might be something to really help you get started, but also to be really effective and efficient in your approaches. And there's always going to be a balance when planning your testing services, including self-testing. Is this something you want to do, larger distribution? Are you going to be focusing on something like first-time testers, or is it going to be focusing on high-risk people who might need repeat testing more frequently? So it's really important to then weigh, what is it that your gap is, and what's the best thing for your program when it comes to outreach that might be really tailored and targeted, or something that might be a little bit broader and lower cost. So you always have to kind of think about that context, but particularly in the Caribbean, key population there, partners of people with HIV. Those are two populations you should really be thinking about how self-testing can help you reach, and what would those models be in your context. And I think it's also important to remember, while yes, we are focusing our testing services towards, helping people with HIV learn their status and start treatment, there is a role for testing within prevention, and that's helping people who are HIV negative to stay negative. So as we were just noting, that repeat testing can sometimes be extremely important as part of prevention monitoring and staying negative. So those that are engaged in, say, PrEP services, that can be a package of things we're thinking about. And diagnosing people with HIV at a high ongoing risk and starting treatment as soon as possible. So maybe you reach people sooner than you would otherwise if you didn't do more frequent testing. But it's really important to think about this as you're implementing a prevention intervention, and testing is maybe a part of it. So the question here for self-testing would be, does self-testing have a role in my prevention program? And I'll just say up front, we don't recommend self-testing amongst people who are already taking PrEP. Under the current COVID situation, I think that we're definitely seeing programs use self-testing to maintain essential services. But what we would definitely highlight, and I'll speak to a little bit later, is something like self-testing might be helpful as a demand creation tool for something like prevention, or a way to have key populations test more frequently if they need more testing. So these are some of the things that you could be thinking about if you're operating, some prevention programs, or even thinking about how to reach the partners of people who are in prevention or the social networks of folks. So there may be a rationale to then think through, what ways you could use testing to kind of build off of existing services more broadly. So, self-testing fits within a broader package for us. And I think that's kind of one of the key learning objectives first here at the top of the training is it's never going to be an independent offer of self-testing without these other services. So it's really important to think of self-testing kind of as a cross-cutting tool that you can introduce in a facility setting sometimes, like especially if you've got partners of people with HIV coming in community settings that might be really targeted towards key populations, mobile outreach, certain types of settings can be very effective. We've really seen a lot of folks gravitate towards the power of social network-based approaches and assisted partner notification, index testing as ways to kind of pass along a self-test kit for multiple partners or a single partner to really expand services. And that's something to really be thinking through. And so self-testing really will sit within a broader strategy that you're doing for testing to reach these higher risk groups. And I think that that's so critical whenever kind of planning self-testing is that you've got that structure in place. So we've come a long way, and I think it's helpful to say, when we've been tracking the development of policies on self-testing pretty closely since about 2015. And now we've got about 45 countries that have policies that allow self-testing and 41 that have policies but are also fully implementing. That brings us up now to about 86 countries with some self-testing policy implementation going on, and about 33 that are now developing policies. So there's been a big increase in uptake, and I think this is very helpful for us to then see a lot of countries are moving towards this, seeing how it can play a role in their programs. But that progress is uneven, and I'll gravitate a little bit here to the Caribbean, that when it comes to policies and implementation, we definitely need to be thinking through, what are those bottlenecks and how do we overcome those so that the Caribbean region and other countries, and as you can see, there's many other regions as well that need to move beyond just having a policy and into more full implementation. So we've talked a lot about self-testing, and I think I'll kind of shift gears a little bit into, when we talk about self-testing as WHO, we are being a little bit narrow, that this is someone who's testing themselves. This is oral or finger prick for their finger prick blood. And all reactive self-tests need further testing. Now, you might be in a setting where there's maybe self-collection, where people collect a sample and then that gets off to a provider. That's great. We won't be discussing that in this presentation, but there is some guidance on self-care that WHO has. And if there's anyone with questions about broader self-collection or other approaches that might be broader self-care, let me know. I'm happy to pass on those resources, but we'll be really focusing on just HIV self-testing for the training today. And when we talk about it, we're always thinking about what's the intended impact of this approach. So, based on what it is and the testing service itself, self-testing really should be something that we're seeing how we're going to increase uptake among people who are living with HIV who don't know their status or are from a high-risk group in need of testing services. The key kind of actions of where we would see impact would be getting folks that are diagnosed with HIV through self-testing linked to treatment, and potentially re-linked back into treatment if they're lost to follow-up. Having the disclosure or shared knowledge of status amongst partners, because there's definitely a lot of evidence on how disclosure, shared knowledge of status is important for partner services, important for people with HIV. The linkage to prevention services. And this last one we talk about a little bit is this value, and I think we're seeing this in the COVID times now, of having a self-test that can be done by an individual instead of that person having to come into a facility to test, especially now where we might have facilities that are no longer open due to restrictions. We might have fewer staff that are available to do testing services. So the value of this triaging out to create some efficiency and to expand coverage when we might have limitations. This is something where we definitely see value for something like self-testing to come in and really alleviate overburdened clinics or services. It may be very helpful to consider, especially during COVID. So all of this is something when you're planning and thinking through, what you're doing in terms of testing, how does self-testing come in? This is really the framework to kind of think through for your program and then design, how will we have an impact by adding in this additional tool? And it will vary. There's no one way, even in a country. It's going to vary by population and by context and geography within a country very often. So now to get into some of the technical details, this is the strategy. So for us, HIV self-testing is what we call an A0. So assay 0 is really telling us that this is a test that's going to help us determine if this person needs further testing by a trained provider using the national algorithm, the first test in the national algorithm. So you can kind of see here that if it's a reactive self-test or a reactive A0, that the information provided to the client would be that they need further testing to confirm that reactive result. And then once confirmed, they should be able to be referred and to start treatment. And that would really be the priority. Now, if it's a negative, we would report this as a negative result. So this person does not need to come in to get further testing. There are considerations here, and it can be a slightly nuanced message, especially if you're focusing on key populations, those at high ongoing risk where the window period never closes, or if this is someone that's a candidate for something like PrEP. So there are considerations here, but we would really say, what are your existing retesting recommendations in country? What would you be advising? And that's the kind of messaging that really needs to come out here, is that yes, this is negative, but retesting should be aligned to the existing guidance. And we would also want to provide information about prevention services and where one could access those. And I think there's a lot of work we can still do about creating demand for tools like PrEP, using self-testing as a way to inform the community and others about prevention interventions that might be really relevant and important for them. Now, I think two caveats that I would really bring in here is, no matter what the result, if someone's uncertain about their self-test result, they really should be encouraged to access testing in a facility or a community setting. It's okay. Sometimes people may be unsure, especially if they're trying it out for the first time. So it's good to have some flexibility, but really helpful to be planning based on this overarching strategy. And then the other key message that we really try to emphasize in our guidance and based on the evidence is that we don't recommend self-testing for people that know their status and are taking antiretroviral drugs. We also don't recommend people who are taking PrEP to self-test. And this is because you might end up with a false non-reactive. Now, there's a lot of variability with that. And I'm sure we could have a very in-depth conversation just on this one issue. But the main issue is that this could come up. And so it's best for folks that are living with HIV and on treatment, but they might be concerned or have questions about their HIV status. We should be trying to address that through other messages. We should be trying to address that through counseling or other support services if folks aren't sure about their HIV status. And more we're seeing folks, especially as our treatment coverage gets higher, that this does come up in countries. So it is something to be aware of, and then just to have a plan for how you're messaging to ensure the community knows about this and is adapting it in an appropriate way so it's clear, and that folks that want to retest or are concerned about their positive diagnosis can really access the support that they need. So now I'll just go into what are the recommendations. So I'll go through the evidence behind this a little bit more in detail. But when we updated the guidelines for 2019, the key evidence really maintained what we reported in 2016 with just a few updates. So first, as introduced already, safe and accurate, highly acceptable. So people continue to prefer and like to self-test when it's evaluated in studies and trials. It increases the uptake and frequency of testing among those at high risk and who may not test otherwise. It had comparable linkage and positivity to standard facility-based testing services. It can be empowering. So the autonomy of being able to test oneself, to learn one's HIV status first, all of those have really been reported as empowering, very building up aspects of self-testing. And cost-wise, it can be affordable and cost-effective when focused. So I think that goes back to the background that I introduced at the beginning of it's got to be planned in a strategic way to reach a population with lower testing coverage or with a testing gap. And so that's really what you should focus on in terms of the resource use message. And we did add some additional remarks about the importance of engaging with community. So, the service delivery options, there are many, which I'll touch on, but it's really important to plan and think through these with the community you're trying to reach. So once you know your testing gap, working with that community, understanding what models, what supports, what tools need to be used, it really does make a difference. And then just reiterating this message that, self-testing, it's a single rapid test, and no single rapid test can provide a definitive positive diagnosis. So individuals with reactive test always need to be advised to get further testing from a trained tester, and they should be using the first test in their national algorithm. And that is, I think, such a core message to say this is, no single rapid test can provide a definitive positive diagnosis. We use testing algorithms. This is a test for triage, and all those reactives need further testing. So as kind of indicated before, this is the background for our recommendation that self-testing should be offered as an approach to testing services. And it's a strong recommendation. And we go through a process at WHO of grade. So it's moderate quality of evidence. And that moderate quality of evidence, really comes down to a self-test is something that, the person who is self-testing is aware there's no placebo. There's no, when we're looking at randomized control trials. So I would say that the quality of evidence here is quite good. And I'm really happy to answer questions on that if there are any. So let me just now move to a little bit of a synthesis of the latest evidence behind this. So I ran through some of those high points, but I thought it would be really useful to at least equip, in the slides, what is the evidence we're pulling from, especially when we're thinking about something like key populations or different regions. So you can see we've got a pretty good diversity of evidence around self-testing, lots of lessons learned. We do have some gaps around transgender people, which is important to note, as well as people who inject drugs. But you can see there's 32 randomized control trials that have been done on self-testing, so a good body of evidence. You can see that while 21 of those are among the general population, 11 are among key populations. So that's pretty good representation when it comes down to a lot of the reviews that we often do at WHO. And we do have good representation across several regions. And you can see there's specifically within the Americas, there are 5, but all are in the US, but we have several other countries as well, coming from Western Pacific and also in Africa. So I'll go through these quickly for now, but I thought this would be useful for your notes later. It's just to show, consistently we see the uptake of HIV testing is higher, or HIV self-testing is higher compared to standard of care facility-based testing or home-based rapid testing in this one. So you can see when it's compared to the existing services, it really does consistently have this effect. And it really does give us some confidence that this is an intervention that can increase the uptake of testing where it is introduced. And that uptake is really seen for the general population and for key populations as well. So this is helpful just to look at the studies, and then by population, where we see that there is that kind of increase in self-testing. And we also see this by service delivery approach. Now, I think this is a really important slide. If you're thinking, yes, we want to do self-testing, but what approach do we take? I think the good news is that there's a lot of options for you. It's really important to think of your context, but whether it be a facility, a community, secondary distribution through partners, including positive partners, there's a lot of options in terms of what could potentially work and what you could try in your setting. And this is just showing, particularly for men, we can see that we have twofold increase in uptake when we look across. And that's using, a variety of different types of men as well. And I think one of the other kind of key evidence points is that when it comes to self-testing, people are always asking about the linkage. Post self-testing, is the linkage different? Well, in studies, the linkage is not significantly different when we compare self-testing to standard testing. And that's really the graph I'm showing, like in blue, that the standard of care is really the same when we look at regular testing in a facility versus self-testing. Now, what's interesting in the orange, that might be worthwhile to explore are, if you're really looking for ways to maximize your linkage for something like self-testing, when we look at studies that compare, self-testing with a linkage intervention to self-testing alone, which is what the orange graphs are showing us, there are options like the linkage escort or some type of provider incentive or promotion. So there are things to think about. And while this is, a little bit more to explore in the orange, it does tell us that there may be some room to think about innovations, ways to optimize the linkage post self-testing. And I think especially now, some of the digital tools and models could be something really worthwhile to consider. But I think overall, the top message is it's comparable to standard testing when it comes to linkage. And maybe we can learn more based on the context and the populations, how to really design something that will help facilitate better linkage overall. And I think when we're talking about linkage, yes, the last slides we were talking about linkage to treatment, but here I thought it might also be useful to highlight some linkage to prevention evidence. So, folks who after self-test link to something like HIV prevention service. Now, these are from the African setting and are for voluntary male medical circumcision, but these studies really highlight PrEP referral. And I thought it might be useful just to show you these quickly to say that, this is something as well that self-testing could play a role in, creating demand for something like PrEP as part of a way to increase, PrEP uptake or as part of a broader, maybe multi-layered intervention. So something that definitely you should be thinking about if you're trying to promote PrEP, trying to think about testing. There could be a lot to learn about putting these two together. And then when it comes to some of the social harm and adverse events, studies really report that self-testing can be empowering, and across the 32 RCTs, there's no suicides or self-harm. We've seen millions of self-test kits with very close monitoring in multi-country studies now, looking at self-testing, showing no serious cases of social harm. And we do see a lot of communities and individuals across all regions really reporting that the benefits of something like self-testing really outweigh any potential risks. And we've also learned a lot in terms of the monitoring, that it's important to have reporting systems. It's important to have support tools like mobile phones or hotlines. You can think about something like community-based monitoring, post-market surveillance, and there are even forms that WHO has that if there is an issue, there's an IVD complaint form, and I've included the link here. But you can report any issues or product issues that come up for something like self-testing directly to WHO. And all the pre-qualified products that WHO lists do have to report on post-market surveillance. So we really do value when countries report to us any challenges or issues. And I'm happy to talk more through that, but something to be thinking about, that we're really encouraged by what we've seen, that there really does not appear that we've had a challenge with social harm and adverse events with self-testing, but we also need to make sure that we have the right systems in place. We're not having to create a new parallel system for self-testing. It's something about how can we bring self-testing into the monitoring, the support systems we have across the HIV response for other HIV testing approaches, and make sure that we're not leaving gaps where then there's going to be challenges or harm that might be perpetuated. But to date, most programs, from the reports have really showed us that this can be done very well. And then in terms of values and preferences, I think overall we see it's highly acceptable across a lot of groups. Sometimes we, especially in the early introduction of self-testing, you might hear about concerns about the lack of counseling and support, or questions about accuracy and cost. But really, with more experience and addressing those in policy, we've definitely seen a lot of users and providers and groups really prefer something like self-testing to standard services. We've also seen a lot of folks always ask about, well, do people prefer blood to oral fluid testing when it comes to a self-test? And we've actually seen now across studies, it's about providing options. Some users will really value an oral fluid-based self-test because it's painless. They perceive that they might be able to do it a little bit simpler. It might be something they think they can do themselves. They might be afraid of pricking their finger. But other participants and users, they really want a blood-based test. So we've definitely seen some evidence that folks that have been missed out of oral fluid-based self-testing, have really preferred a blood-based self-test when offered. So I think that the main takeaway here is, if a country or a program can provide both options, that could be really ideal. But it's something to be, thinking through, giving people choices, orienting people to the products that are available, and ensuring those products are quality. And when it comes to the service delivery preferences, I think we've seen a lot of variety across settings, but in key populations, we have seen preferences for things like pharmacies, the internet-based approaches, the social networks, to be able to get it through friends, over the counter, different options that might be more discreet and private, definitely being very appealing. And I've included a little bit more detail for those that are interested with kind of our latest update on values and preferences, that, you can see that there's a lot of diversity across groups, but something to think about and, really highlight to you that there is this high willingness and some concerns and issues that might need to be addressed, but most of that can be really addressed through messaging at the policy and program level. And then on costs, I think before I jump in to the costs on something like self-testing, I wanted to kind of frame it to you to just highlight, testing service costs is really difficult to actually combine these. So we did this review back in 2015 to look at median costs across different countries and populations and testing approaches. And what we really see is the costs vary widely. And so you can see that depending on where the service is being implemented and the population, there's going to be big differences. So when we frame something like self-testing, and this is drawing from some studies where they had collected cost data, these costs can be relatively similar. So here in this setting, we're looking at costs coming out of sub-Saharan Africa, and I don't think the actual costs are necessarily the most important here, but the way they relate to each other, which is that, facility, community, and self-testing are roughly in the same ballpark. And we're also not factoring in some of the equity issues, the opportunity costs, and how self-testing can really reach people who wouldn't come in otherwise. So it's a crude representation here, but it is to help kind of frame that, testing costs vary widely. We always need to be paying attention to those resources. And while the unit cost of a self-test kit might be higher than the cost for a professional use kit, the service in which it's used in and how it's targeted can really be comparable. And that should be kind of the focus if you're thinking of, optimizing your program and where you can really, make the most out of the resources you have. So now just to move forward a little bit to some of the products and usability information for self-testing. I think the first thing I wanted to highlight is, often when we think about self-testing, depending on the context or country, there can be confusion about what is a self-test. So, you'll all probably be very familiar with professional rapid tests, and these are just a few that are highlighted here to the left of what those professional use versions look like. And then there's the self-test version, which is using the same technology, but coming with different packaging, different instructions for use. You can see the differences in instructions for use, perhaps with the OraQuick product, which stands out maybe. You can see as well slightly modified Insti product that doesn't have the pipette. There's differences across each, so it's really important when we talk about products that we're always talking about the products which have been designed, evaluated, and pre-qualified for self-testing. And we're not talking about adapting a professional test, and then using that as a self-test informally. We're really talking about these products that have been evaluated for self-testers. And when it comes to self-tests, we really think about accuracy and usability. So for self-testing products, nearly all of them have been adapted from existing WHO pre-qualified products that are already registered and being used in a professional context, by a trained provider. And these products, they have an existing standard where they have to have at least 99% sensitivity and 98% specificity. And that's, I think, a really important piece of background when it comes to the analytical sensitivity and specificity, the performance of the test, its inherent qualities. But then when we take it to the self-testing level, it's really about communicating usability. So we might be looking at how a test and how the product is used in the hands of a self-tester. And a self-tester is a diverse and non-uniform group with varying levels of literacy and education. So in this way, a highly accurate HIV rapid test for professional use, it could actually perform poorly. And it's not because the technology is different, and it's not because the test isn't a good test, but it might be because of design, labeling, packaging, things that weren't clear to the user. So for us, we have to look at both of these aspects when considering something like a self-test. And early on in our work, and this is a paper from Figueroa and colleagues here, about the reliability of self-testing. And when you're thinking about this accuracy and usability question, I think it's really important to kind of pull out that we want to, we've kind of gone through this work on self-testing before, that a good self-test performs just as well in the hands of an untrained self-tester as it does in the hands of a healthcare worker. And this is a systematic review that really showed that self-testers can reliably and accurately self-test with rapid diagnostic tests for self-testing. So this is something that we've really learned through our work, but it is important to ensure that that product is also meeting, your inherent quality standards at country level. Pre-qualified products is another great list to consider, but we really have to kind of hold both of those concepts when considering products. And I just thought I would pull out some of the variability here that you can see in the rural settings, even with high agreement and performance. This study here, that's a bit of our outlier. It's in a rural setting where folks, they needed to optimize the instructions for use. They needed to make changes. So this is an early study from 2015 that, since that study, the manufacturer then was able to change the instructions, improve the product, and now we have a product that's pre-qualified that performs very well. So I think that's something, if you're looking at products, to really think about and then consider that usability piece, because it is very important to the programs. And this is maybe just for notes later, of just saying, when it comes to sensitivity versus specificity, when you're looking at studies, really the sensitivity is where we've seen the greatest variability in the past, and something to make sure you're paying attention to in your selection, or just aware of, because there are considerations that even if sensitivity is lower, but you are increasing the uptake of testing in a high-risk group and getting more folks to start on treatment and initiating prevention in high-risk groups, there are different trade-offs around the products that you might select that really have to check a lot of the different boxes. And this was an analysis that we did that was presented at the AIDS conference a few years ago, that did talk about the clinical utility framing, that it's about how the self-testing can achieve the most impact and benefit. And it's not just about having a product that's 100% sensitive and specific. I think that would be ideal, but given the product that you might have and the variability of usability across different populations, it's something to really think through in your setting, that what's appropriate and what can really be used to achieve impact, and that's going to be useful for the HIV response. I've touched on this already, just about the impacts of ARV drugs, but this is just a useful reference from a meeting report, and the considerations around folks that are on treatment or PrEP, because we really don't want to encourage self-testing in those groups. And just to highlight, I know I've gone through some of the studies, but our website as WHO, we've got kind of 3 ways in which we look at the quality assurance or evaluate products for self-testing. So in addition to what's done for rapid tests, we've got a labeling study, an interpretation study, and then an observed untrained user study. So this is just giving you some of the specifications, and all the information on each product that's pre-qualified is available on our website. So you can look at some of those study results and see kind of, what might be the best self-test for your context and for the population and the setting that you're in. And this is a little cheat sheet of the products that are kind of CE marked or in the pipeline. And those highlighted in green are the 4 pre-qualified products. Now, the pipeline is very strong for self-testing. We've got products that are already kind of being evaluated by PQ and the ERPD at Global Fund. So it's something to kind of continue to check in on. But starting out with these 4 products, they can be procured through Global Fund for between $2 and $3.10. And I wanted them just welcome our colleagues from PAHO. Perhaps you can speak to some of the considerations around the strategic fund. That would be really great, I think, just to touch on here to frame that, in the context of this region.
Sorry, I had was fumbling there with my mic. The PAHO Strategic Fund is a regional technical cooperation mechanism for pool procurement of essential medicines and strategic health supplies. It's a mechanism that is available to all member states. So ministries of health can procure directly through the strategic fund. And the list of medications for HIV, malaria, and also for NCDs are available, and they are all WHO pre-qualified products. I know we have circulated in the region, and we have done several different webinars on the PAHO Strategic Fund, but this is something that we could perhaps look at in more detail if a country or if PANCAP see it as a critical area to actually promote again in the Caribbean. And the strategic fund, I must emphasize here, is not only for the procurement, for pool procurement, but it also seeks to strengthen supply chain management, providing technical cooperation to plan demand and guarantee the rational use of medication, as well as stock out, which we know is very prominent in this region. I also must mention that the kits that for the HIV self-test kits that Cheryl also mentioned, they are included in the strategic fund. So I will just say that much for now on the strategic fund, but this is something we could do a follow-up session on if it's required. Thanks, Cheryl.
Wonderful. And I think it's such a great thing in the region that you have the strategic fund that you can take advantage of. And it's a great thing to then be able to really accelerate access to some of these products. So just really fantastic that that's available. And I just wanted to share a little bit of the news that you might also be seeing in the manufacturers, some slightly different packaging options. I know there's different SKUs, there's different instructions or versions, some that are sold in the private sector for the pharmacy, some that might be in a pouch. So it's just important to know what you're getting and what you are really procuring, and that information you can definitely access on the WHO website, but also through the manufacturers as well, as there's a variety of different SKUs and types. This I thought would be just kind of fun sharing here in Switzerland. When self-testing went on sale in pharmacies, there were some different packaging options just across the border in France to what we had here, different pricing. NGOs were offering them for free. So there's a variety of ways that can really be considered. But one thing that was pointed out to me early on, in the Swiss context was, the cost of a self-test, even though 50 to 60 francs sounds like a lot, is much cheaper than the standard blood-based test, which was being charged and performed at labs really exclusively. So that's another option, just increasing access, and that's going to vary country to country, but just thought I might share a little bit of the context from our country of how self-testing is really being used in the private sector and through internet-based approaches here. So I think in short, some of the things to think about when you're selecting products or considering products for self-testing, they should always be highly sensitive and specific. They should be simple to use, have the necessary consumables like a swab or a plaster, like a Band-Aid if they are using that finger prick. They should really be easy to interpret. So the products that we have that are pre-qualified, I think it's between 1 and 20 minutes that they can be read. So something that's short, and all the products we've pre-qualified are also designed to be disposed in the general waste system. So blood or oral can be disposed of safely. That's how they're packaged. They come with information or a disposal bag. So there's information on that, but that I think is a question that always comes up, I think, in trainings or discussions, is how should the kits be disposed? And that's definitely something the pre-qualified products have considered, but especially if you are coming from a national regulatory authority or other groups that are looking at products, definitely should be considering that. And I think it's also important that the products be accompanied or have some clear pictorial instructions, because we know some users may have varying literacy levels. They might speak different languages, and it's important to have support tools and information about where to go and what to do after a self-test. Videos, websites, all those things have really been very effective and can be prioritized. And we also really think it's important that products are robust, so that they can accommodate some user errors and mistakes. The products that have been pre-qualified, the robustness is something that we definitely take into account. But that is something, if you're looking at a product, it's not just about being a good test. It's about, can it sustain suboptimal storage, or can it sustain some user error? So it's good to have that kind of factored in as well, because it's just so important once you're delivering this test to someone who might be keeping it in their house or using it in a few months after they pick it up. It's something that we really do want to do the best we can on that side. And then the costs, just as I was mentioning before, even if the unit cost is higher than the unit cost of a professional kit, it's always important to plan and think about the cost of the service delivery of the self-test compared to the cost of the service delivery of a testing service, not just the kit themselves. And providing options is something we would definitely encourage for programs to consider, so they can really reach the variety of populations that might prefer oral or might prefer blood. So now on to just a few implementation considerations. I've touched on some of the different support tools that one can consider. And, we've had a lot of good experiences to date with self-testing around in-person demonstrations. So these can be done, really in 3 to 5 minutes, a one-on-one, or with groups or partners, a brief how to self-test and what to do. And we've also seen a lot of the programs, especially now with COVID, move those strategies over to online links and videos, where you can have that 3 to 5 minutes or even less, really, to do a quick how-to tutorial on the self-testing and provide additional information on where to access additional confirmatory testing services, support, etc. Telephone hotlines, especially in countries that already have HIV/AIDS related hotlines. We've seen a lot of programs capacitate their staff and folks that are answering phones for these services to provide information on self-testing, so that's something to consider. Short message services, either through the telephone or through internet, social media, so WhatsApp has been a really popular tool across programs where we've seen countries and different NGOs set up their own WhatsApp for business, and then really provide the chat service either through kind of a bot, that kind of an AI technology that's kind of programmed in to respond to some of the queries, as well as then directing to some hotline service or clinical staff. And we've got education brochures, other types of information that can be accessed either through tablets, and local information really being so important, depending on the context, where PrEP might be implemented and available, that can be something to really be highlighting to specific populations, as you are rolling out support tools and integrating some of the messages that might be really relevant. And I think maybe just to kind of then come back almost full circle to the beginning is thinking about where to begin with self-testing. You'll first start with knowing your epidemic and your testing gap, thinking through, what approach, what service delivery point might you want to focus on, and then working through the scenarios of the benefits and risks to the population, the support tools, the linkage. How will it increase access? How will it increase coverage? And really then developing that mobilized service delivery and linkage plan for the testing strategy. And this is something you'll design, maybe say if it's key populations you're trying to reach, you might pick a couple of these approaches to try. If it's maybe more just men focused, you might be thinking about some other options. And we've learned a lot about testing and self-testing during the COVID times that, we've done a WHO survey here looking across countries facing disruption, and testing services are one of the most disrupted and are the most disrupted service from our survey, where we've really seen programs slow down, fewer clients coming in or no clients coming into some facilities. And especially, settings with very high-risk populations who need more frequent testing or have higher risk is something where, getting those HIV testing services to them is a priority, is a challenge, something we really want to make sure we're supporting people with HIV who are undiagnosed so they can start treatment is really important. And we've seen that we really need to probably plan a lot more around avoiding stockouts, that programs that might start to use something like self-testing, they may not have very many kits in country. So it's important to start that planning now so that those kits will be in country, and especially when they're needed most. There was some guidance put out by WHO and partners in June, highlighting kind of some of the ways you could maintain essential HIV testing services with self-testing. Continuing index partner testing, social networks, digital tools, enabling retesting for certain populations. So I think this is a really useful tool to consider. And just to pull out a few of the highlights, one is, if you're doing index testing or social network-based testing in your program, and due to restrictions, you're not able to either continue or maintain at the previous scale, self-testing is a great option where you can really use that in index testing programs to make sure you're still getting folks access to testing when you may not have sufficient staff to do so or may have limitations. Priority settings to consider might be at a facility, especially some of these where higher risk clients might still be coming in. Community sites, especially that are focused on hotspots or higher risk communities. Online platforms being really important. We've got several programs that have used distribution through the mail, pharmacies, retail vendors, vending machines, online services like websites and social media where they've been able to order and then pick up kits either through the NGOs, community workers, or just e-commerce sites. And other things to really be thinking about, is how self-testing can then be used in this context, to really promote getting countries to move forward now, because with COVID going on, we see, an inherent value of having this additional tool, very important for programs to introduce, and the policy changes or ways that you really need to be thinking about is, taking advantage of the opportunities right now, because in a couple of months that may become even more challenging again, placing those orders, making sure that there will be sufficient test kits in countries for 2021 is definitely something I would highlight to this group for your strategies and planning. And now to move to some case examples, probably my favorite thing in any presentation. How are programs using self-testing? And so I thought I might walk you through a community-led model in Vietnam. This is a paper from, I think, 2019, which I think is a really great example to think about, applicable to the Caribbean context, perhaps where you're focusing on perhaps key populations, partners of people with HIV. What I love about what the authors of this paper and what the program did here was they really focused on a community-led model. So working with the community lay providers from key population groups to design a package of services where it's not just self-testing alone, but it was a variety of tools to then say, oh, we're going to have key populations from the community offer testing through coffee shops, through social media. We're going to follow up with the partners of people with HIV, and we're going to offer self-testing. And so they did all three of those together. And they even also offered integrated testing with HIV, syphilis, and hepatitis. So they did offer a variety of things in their program, but over several years now, they've been able to really see some great results about not just with self-testing, but for a community-led package that definitely is reaching the population that needs testing in their community, supporting very good linkage to care, and really seeing more people tested that were otherwise missed. So I think this is a great example to think about, you know, not just designing, hey, we're going to do self-testing, but thinking through a community model that offers options. And since then, they've adapted some of their work in Vietnam, you know, focusing on using online risk assessment, orders, doing test kit delivery, and then follow up all digital or with via telephone or SMS. So it's something just to say you might be able to take a community-led model, and then if you're thinking, oh, how do we adapt this to COVID? There really are options and some things that appear to be working quite well when it comes to then saying, oh, you might be able to get it mailed to you. You might be able to get it picked up. We might be able to have someone deliver it to you. You know, there's a variety of things that you could think through. And they even created their own stay home self-test branding. So something that has been really popular in this setting. And likewise here, I just thought just to highlight another good example, you know, in that COVID context is something like index testing, which is such a priority in all countries. We're adding self-testing into the notification system. They've either had the product at home or handed off at a public location. Then the self-test results are kind of followed up digitally and then promoted and followed up for referral to the AIDS center that they have in country for confirmatory testing and treatment. So they have kind of created their new continuum of care for index testing and have really been able to use this as a way to sustain index testing during COVID lockdown and restrictions. I've got a number of references that I thought just might be good for the future, some data resources, some decision frameworks and guidelines, and also just some really useful papers when you're thinking about strategic planning, a variety of background pieces that also might just be really useful to think through. So thanks everybody, just all the folks who support the testing work at WHO and all the colleagues from PAHO who've really organized this. I'm really glad to be speaking with you, and I'm very happy to answer any questions that I can today. So thanks so much.
Thank you very much, Cheryl, for that very wonderful, detailed and comprehensive presentation. I think it has provided a lot of information. It has highlighted some of the key questions, issues and concerns that have been discussed in different settings in the region as it relates to the implementation of HIV self-testing. So thank you so very much. And I think that the information that you also provide will clearly guide strategically the advancement of the HIV self-test in the region. I'm sure participants may have a lot of questions for you, so I will not even go into some of the points that I wanted to summarize. I think for the sake of time, we should go directly to the questions. I'm trying to see. So let me see, perhaps I may ask Timothy or Shanti if there's available to also help me with some of the questions. I'm trying to look to see what are some of the specific questions. I just want to remind everyone that they can just go online and just type the questions if they do have any questions for Cheryl. I'm just going through them quickly. I am not seeing specific questions.
One thing I would say too is I would love to hear from folks if you are trying to introduce self-testing and having different experiences, success, challenges. It would just be great to learn from the group as well, especially any of you that are implementing some models under COVID restrictions. Would love to learn more from your experience.
Right. I think questions asked there's some questions asking if the presentation will be shared, and yes, the presentation will be shared for all those, but it will be shared by PANCAP. I see a question here. This person said, assisted self-testing, what are your thoughts, experience in implementation? But yes, I don't know if this is something that you want to actually summarize.
Totally. Yeah, well, it's a great question. So thank you so much for raising this. So as background for folks, when we talk about assisted self-testing at WHO, we're talking about, it could be a peer, it could be a trained health worker that helps somebody perform the test and maybe and supports them in that process, assisting, when they have questions or just with doing the test itself. And then unassisted testing would be when we don't have that assistance readily available in person. And there's a lot of variability in how assisted models can work. Sometimes it's, just the demonstration that's the assistance, and then the person takes the kit home. Sometimes it's no, somebody really does need support doing the test. So my kind of thoughts on it and the evidence and programs that we've seen is, especially if you're just starting out with self-testing, often with ministry, often with stakeholders, it's helpful to have some assistance early on, really because it just helps you learn more hands-on about the program and how people are using the test, and where they have challenges that you might need to then address, or improve your communication materials or improve your service delivery model. So I think early on pilots, very early implementation assistance can be very meaningful. And then usually programs graduate into, less and less assistance, and then having more fully unassisted models. And there's going to be some variability because in some countries, when we started out with self-testing, there were no self-test kits. So people really were confused. They didn't know, what is this self-test all about? And, it was kind of an orientation. But over time, as people got more familiar, they didn't desire those assisted models as much. So I think that's where I would say, in general, it's perfectly fine for programs to start with assistance. That should be probably talked about at the community and country level about what that assistance should look like at the beginning, but then kind of have plans to gradually remove some of the assistance, so it could be a scaled up, cost-effective, more affordable model, because the assistance can be expensive. So it is important to kind of think through the resource implications. And the other thing I would highlight is people should always be encouraged that they can get assistance if they want. So, even if they want to self-test but they want to maybe test with a buddy, we've seen some success in some buddy self-testing models, especially in the US. That was one for young men who have sex with men, young people in particular. A buddy system could be something that's, empowering and supportive, useful. So I think that there could be a lot of ways to plan assistance in a way that's helpful to the program. But I don't think you should be thinking about it for all populations or for the long term. It really might be something that's, for a specific group, something that's accessible to folks who need it, and then something that you might start out with, but have plans to kind of scale down or, really move to some different unassisted models as the program matures.
Thanks. There's another question. How can we verify the results received, since clients may not always be truthful?
Can I ask a follow-up? What do you mean by verify, and who's verifying?
Right. I am thinking that it may be in relation to the person who has well, perhaps we should ask the person who has asked this question, if they could just clarify in the chat section. In the meantime, I would like to move to another question. Is there data on possibility of persons with reactive tests who refuse to continue the testing algorithm at the health facility?
You know, this is a good question. I think I would say not everybody might be ready to do confirmatory testing the same day that they get a reactive self-test. You know, we've definitely seen some data. You know, there are folks that might want to self-test again to confirm that reactive test before coming in. They also might need some time to process that reactive result and then come in, you know, later. So there is some variability, but I haven't seen anything on someone refusing to go for confirmatory testing after a reactive test, but there is some, you know, variability in when someone feels ready to really come in for further testing and, you know, starting treatment.
Thanks. I think in relation to the first question that I read, which says, how can we verify the results provided since clients may not always be truthful? I think it's talking here that the person may say that they have a negative self-test when it may actually be positive. But I think there would be a process in that individual linking into the health system. Maybe you could just perhaps clarify that, Cheryl?
Absolutely. So, you know, it's a great question about the challenges with self-testing data, and I can see a lot of directions or points maybe to raise here, which is, you know, one, with self-testing, we're trying to create access to testing services, and we're not going to have as much control over the data that we do through standard testing. So we kind of have to approach it with different expectations, and how do we know what we know? So I think one thing I would say is, of course, you can try to ask people the results of their self-test or if they self-tested before coming into a clinic, but you probably won't necessarily be able to get that routinely. That might be something you get through maybe a small sample, through some kind of special survey or some follow-up with certain patients, et cetera, or through a pilot program. But with routine data, that's not something you'll really be able to get at most of the time. So I think just when you are collecting it, just be very cautious with the and not to overinterpret that data. And the reason I raise it is sometimes you might have folks who self-tested and they were unsure of their result, so they don't know if the result was reactive and they're coming in. You might have folks who self-tested reactive and don't want to tell you that they were reactive. Absolutely. And you might have people who come in who self-tested but don't want to tell you at all. So I think that it's really important to think through data collection tools that are going to be meaningful. And on our side, we collect data and we encourage programs to think about routine data systems, about the number of tests distributed to certain populations of interest. And trying to collect some of that, and then to use some quality improvement tools, perhaps at site level, do some sampling so you can kind of triangulate survey data with some routine data around awareness, willingness, use. That really then gives you the indication at you know, at key populations or at population level, you know, who's really accessing the service and are they linking and getting into care, and trying to have site level tools for that. But I just would be very cautious about interpreting, you know, is the client being truthful? Well, I think that the key thing is if the person gets a reactive test and they come in and they get tested and start treatment, that's success. And we want to make this as like an option, like when we distribute condoms or we distribute services. This is a way to increase access and reach, you know, this remaining people with HIV who don't know their status. And it's a very different approach than it is through standard testing services.
Thanks, Cheryl. And I think one of the things that you mentioned early in the presentation is to keep in mind that the result is not definitive. You know, it has to be linked into
Exactly.
algorithm for the health system. So I think that is the key there, and how you're going to track the HIV self-test result and then coming back into the health facility. Yeah.
And on that, one thing, especially if there's anyone thinking about, pilot data or early program work, one thing I know we worked on in a couple of countries is when you track the number of test kits distributed, maybe in a certain geography or through a certain population, you can then follow up to see, did more folks in that catchment area or in that population start treatment? Did more people get tested at facilities? Was the yield higher? So there's bias, but it's a way you can kind of triangulate your data to say, is this intervention working? Is it helping us achieve impact where we're reaching the right people and we're getting those folks into care?
Right. We have another question. Someone was asking if there is an age restriction as it relates to the HIV self-testing.
It's a great question. So not an easy answer. So the key thing I would say is age of consent varies country by country. So WHO doesn't have like a recommended age for self-testing. We recommend the approach, and then countries really would then adapt this to their existing laws and policies on like the age of consent for standard testing or special provisions that they might need to put in place. So for example, I know, say in South Africa, the age of consent for HIV testing is 12. So for them, when they were introducing their national policy on self-testing, they didn't want to limit access, but they did say, if adolescents, from 12 to I think 16 wanted access to self-testing, they could, but they would promote assisted models for that population. So they weren't going to limit access, but they were going to prioritize implementation approaches that were maybe more appropriate. And that was kind of their feeling. And I think there are definitely a lot of countries that we see the age of consent for testing is generally closer to between 15 and 16 in a lot of settings. And so that would be, access to self-testing seems to be, in many of the countries implementing that would be aligned to their national policy. But there are some countries that have definitely included some provisions to say, maybe our age of consent for testing in a facility is 15, but our age of consent for accessing self-testing would be 17 or 18. So we've definitely seen some countries with policies like that. So what I would really suggest is, think about adolescent Q populations, or think about the folks you're trying to reach, and align as a first step, align your self-testing policy to your national testing age of consent. That's like probably a good first step. But you might also want to be thinking about if your age of consent is, higher, maybe it's 18, you might want to consider, is it appropriate? Is it something that would be helpful if we were able to use self-testing as a way to talk about the age of consent for testing and maybe reducing that down? So WHO does encourage countries to review their age of consent policies for testing and really make sure that they're aligned with the epidemic and the populations they need to reach. Happy to talk through that more in detail if that's ever helpful, because there are maybe some different models you might want to consider if you are trying to really target maybe an adolescent key population group.
I have another question here in which it's asked, well, the person says, thanks very much for the webinar. I observed that the Caribbean region is still behind with this strategy. Could you please share the rationale? And I think maybe some of us know why the rationale. If a country is interested in implementing self-testing, what kind of support would they receive from WHO? I just wanted to just add here, and then perhaps Cheryl can actually jump in after, is that, and perhaps I failed to mention it at the beginning of the training, is that this training is actually going to be linking to intervention, and we will be discussing before we end this training what are going to be the next steps as we move forward towards looking at the feasibility of implementing HIV self-testing in the region. If a country is interested in actually moving forward, as I said, under the PANCAP Global Fund Initiative, this is one aspect, or you countries can contact the PAHO country office, and we are available to provide technical support to actually advance with the implementation of HIV self-testing at the national level. I don't know if you have anything else, Cheryl, that you want to add to this particular question.
Yeah, I think that the first thing I would say is, from what I can see in the global reporting is, supporting countries, whatever organization you're with or with PAHO, to get that policy in place, get some implementation going is such a priority. And it seems like that for me, like just because we are monitoring policy and implementation, that is a gap that we see. I think the strategic fund, as colleagues had mentioned, getting these products registered and procured at country level, so critical. I think the sooner that advocacy, the support to get started with, some implementation, once you kind of start with this approach and really see the value, I think then it becomes so much easier. So for instance, I think with COVID, there's a lot of momentum for the self-testing approaches. And I know like CDC and the domestic CDC in the US and others have really started to transition to saying, yes, we really want to focus on self-testing because we need it, where I think before it was maybe less emphasized. So if you're in a position where you can advocate at country level, I think now is the time. On our side, we would of course, support our PAHO colleagues and answer questions if there were any, and we're very happy to field questions from the countries, and also, to even raise this in Global Fund, that there's a lot of opportunities there that you can definitely make the most of. Self-testing is very much highlighted in this year's Global Fund funding requests, and the differentiated HIV testing module. This would be a place where you really need to talk about the geography, the population, the implementation models, and that can be really helpful for getting the resources to implement.
There's also another question, I think, and two of them are very interrelated, so I will just read them as one. Do you think that persons who self-test and are positive will report their status to the healthcare provider? I think you perhaps alluded to some of this already. Persons that have perception that someone gave them, so they will, yeah. So how do you, let me just repeat the question, sorry, because I think I was jumping over my ahead of myself. Do you think that persons who self-test and are positive will report their status to their health provider? Persons who have the perception that someone gave them, and I guess HIV, so they will, or someone gave them the test so they will spread it to others. I gave them HIV so that they will spread it to others.
So I think if I'm understanding the first part, which is, if somebody has a reactive self-test, will they tell the health worker? I think that it's going to vary person to person. And I think it's just important that if you're trying to collect some information or you're trying to understand, just ask in the logbooks or just ask at the facility, did you self-test before coming in? And if the person says yes, then you could ask, are you comfortable sharing the result with me? And they may say yes or no. And so I think you have to just remember, for something like self-testing to work, it's appealing because it's private, it's confidential, it's, patient kind of controlled. And once we start to kind of try to, collect too much information or chase up too much on that, it can start to really defeat the purpose of the additional offer, and it turns into the same facility test the person didn't want. So I think you just have to be very cautious about how you approach that. But I think there are many programs that are asking when folks come in, hey, did you self-test before you came in? If so, are you comfortable sharing the results? reactive, non-reactive, great. But I would just say this is a self-reported data and it's going to have bias. So you would just be very cautious in your interpretation and note that there's going to be a lot of people who don't want to share that information or who don't feel comfortable sharing the results, even if they are comfortable saying that they self-tested before coming in. Now, I think the last part I was slightly confused on, but it was asking, you know, if people are going to give a self-test to someone, like, sorry, can you just rephrase that last part? Because I wasn't sure, is the concern?
Yeah, I'm not too certain what the concern was also, but I'm trying to see if I could get back to the question.
Well, if the question is, will people who give a self-test to a partner feel like the person who gave them the test kit is positive? Like, you know, if it's a question about stigma, I think it's a really important question to be asking. And this is where I think it's similar to like when you might have antenatal care or partner services, when you're doing like a male partner invitation for testing. I think that you might really need to consider that, oh, this has to be messaged appropriately, that it's an invitation to test, or it's not necessarily, oh, I'm positive and therefore I want you to self-test. There are a lot of people that will use a self-test though to disclose, and it is for that purpose. And I've definitely seen in those cases sometimes both people having a self-test to disclose together. That's definitely been a model that some countries and some programs have used and has actually been very well liked in some settings. So something to think about if that would be appropriate. But I think it's about equipping the partner who's giving the self-test kit to someone else with the messaging. They need a little tutorial or training to address that stigma or that concern or that question, to say, oh, this is an invitation to test. Everyone who comes in gets one. Because yes, in a relationship, whether it's a self-test or any HIV test, when you invite your partner to test, it can raise personal questions. It can raise challenges. It may undermine trust in the relationship. And so it's really important to think about any time you're doing a partner testing approach, that people are sensitized to, okay, this is how you can present this in a meaningful way, in a way that's helpful, that addresses concerns, that you're not, you know, it's not uncommon when you talk about HIV testing for issues of fidelity and trust in relationships to come up. And I think just light training and discussion with the provider or community worker who's giving the tests, that can really be helpful.
A slightly different direction. My concern would be with, and this is a question, my concern would be with reactive results and presenting for further testing. Are there models of self-testing that allow for follow-up by healthcare providers? For example, if the test was acquired by an NGO.
So I think there's lots of different models, and I think what I would say when it comes to routine programs and implementation, you're going to distribute test kits out. You won't necessarily know the results or be able to follow up with each person who gets a kit. I think that I would say if you're asking that, then no. But there are ways where you can do like some follow-up, like if people volunteer or share phone numbers or information, where you can send a reminder that you can do some follow-up for confirmatory testing. They're definitely using like WhatsApp and social media. We've seen some programs do that. That can work very well. So if that's what you're asking, yes, there can be some models, but I just really want to caution that that's not going to be for everybody. And so it would be very difficult in a routine program to do everyone getting, you know, the health workers doing the confirmatory testing for all people who got a kit, because you won't really be able to track every single person who gets a kit. You'll only be able to track who you distributed it to. They might give that kit to someone else. You might have social networks or partner approaches. So it's something where you just want to be mindful that you won't always have that one-to-one level follow-up information.
Sure. Okay. I think we'll take 3 last questions here. One says, what are some of the strategies used for pre-test counseling, especially when self-test kits are distributed in the community?
Great question. So I think the first thing I'd say is we don't recommend pre-test counseling for general testing anymore as WHO. We recommend brief pre-test information. So it's really about the core messages, brief kind of information that you provide. So I think that's really important to make sure that that's generally observed and taken on board for testing programs in addition to self-testing. In the community, when people are talking about self-testing, I think that it's really helpful to ensure that you're saying this is for people who want to test themselves. It's voluntary. You know, as with any testing, it's not mandatory. So these self-test kits can be used. Reactive tests need confirmation. Here's where you can get treatment. If you have a negative test, be mindful of prevention services and retesting if you need it. Where can they access support and information if they need like a hotline, or if they have questions while doing the testing? Is there any place they can go or people they can talk to? I really think there's a lot of power in the videos that we've seen. The digital videos have been really great tools where people can follow along on their phone or online. And that really does help a lot of folks just kind of do the testing process and get the information they need. So I think there's not one way, but you could certainly talk about videos, brief community information that's provided for folks distributing the kits. I've seen pharmacies that have like short videos playing on loop sometimes about the self-tests and how to do them. You can have, I guess it's hard to say because there's so many different ways where it can be individual or group level for that pre-test information. And I think it's also important that some people might already know. So you just say, okay, if they know and they want to pick up a kit, that they can just do that. As with standard testing, you know, if someone consents and wants the test, you know, they should be able to access it. We don't want to be a barrier to them testing themselves. You know, if they're ready to do it and they want that access, it's important that they can go ahead and do that. And that's the power of this approach.
Right. And this will be the last question. There have been so many questions, Cheryl. I've been trying to go through them. This question, is there a recommended best practice to monitor the dispensing of HIV self-test kits and for the reporting of the results? Any best practice to share or good practices?
Yeah, you know, it's a great one. So for reporting, what I can maybe do with this group is share around the self-testing framework, and we do have an M&E module. And what I would say is the best practice would be triangulating the data that you have. So a best practice we've seen is programs that are able to take the number of self-tests, you know, distributed to certain populations. So collecting some information on who's getting the kit and where they're getting the kit. And then knowing the service delivery models that are being used, so you're tracking the actual implementation, and then triangulating that with the actual program data to see, are those folks, those same kind of population groups or folks in those entry points, are they then getting confirmatory testing? Is the yield higher in those facilities? Are more people getting treatment? Has PrEP uptake, if you're targeting more of a prevention demand creation goal, is that increasing? So it's really about the triangulation of how you can take routine data and bring it together, you know, to say, oh, okay, we're reaching that right population, and I can see it through the treatment increase here and the testing increase here. So I think, you know, especially if you're doing something, you know, in the Caribbean targeted more towards key populations and their partners, I would be thinking through like what data sources you have and how you can add in self-testing, you know, number distributed by population, by approach, by setting, and triangulate those as a first step. And I think that's been super helpful for some programs, because then you know, oh, okay, we're doing something right here. The right people are getting into prevention and care. So I would highlight that for sure. I've seen a lot of really interesting stuff with the digital tools. So there were several programs doing some like rebates or airtime trades of saying, hey, if you share data with us, and they're really taking a sampling approach. So of the people who take a test kit, they would collect phone numbers, and then I think it was like between 5 and 10% of those who took kits shared some data about, yes, they did the test, what the result was, and if they, got it confirmed and started treatment. Now, this is not a one-to-one, but then you can use some of that information to extrapolate or to understand more about the self-testing implementation and triangulate that further with things like the number of kits distributed to who and by the different type of setting, and then that routine testing and kind of treatment program data and prep data. So I think the key for any best practice with self-testing is how can you use what you already have, and how can you bring self-testing data points in to help tell the story or understand if you're reaching the right people. That to me seems to be the best practice for like routine program data. And I'd really encourage people to think about routine data systems that can work, because you might pilot self-testing and be able to do things like individual linkage, but once you move to a full-scale program, you're not really going to be able to do that. So it's important to kind of start mapping, what data systems you have and how you can leverage them best.
Okay, thanks, Cheryl. I know we have a number of questions that we were not able to actually address, but we will respond to them through email, and then well, I will be sending them to Cheryl. And Cheryl, if you'll be able to support with responding to the questions, and then we will be able to send the response back to the various to all who participated in the webinar. I know we have 10 minutes before we end, and but we need to we have two more important points on the agenda that we want to do before we close this session. But just before I move on, I would just want to say a very big thank you to Cheryl for the excellent presentation that I mentioned, very comprehensive, and I think it gives the region information that we need to actually package and to see how best we can move forward with HIV self-testing at the national level and as well within the entire region. As I had mentioned earlier, this training is not in isolation, but it's also linked to actions that are proposed for the introduction, looking at the whole verification and feasibility of HIV self-testing in the region. And so we'd want to just, for us to critically look at the next steps. Where do we go after we have had all this information presented to us on HIV self-testing? What is the next step? And so I would call on Miss Valerie Wilson from the Caribbean MedLab Foundation to walk, followed by Patricia Smith-Cummings to walk us through the anticipated next steps. Valerie?
Hi, good morning, good afternoon, I should say, everyone. I hope you can hear me.
Yes, we're hearing you.
Okay, thank you, Sandra, and thank you, Cheryl, for an excellent presentation. It's really been very helpful, I think, for us as we look at moving forward. The Caribbean MedLabs Foundation has actually been working with PANCAP and with the OECS under their Global Fund grants to undertake the introduction of HIV self-testing, given the realities of COVID-19 and the examples that you presented in terms of how self-testing can really assist given the conditions. And in terms of next steps, we have already drafted a protocol. There has been funding assigned within those Global Fund projects for both PANCAP and OECS countries, 10 countries in total, to look at introduction of HIV self-testing, purchase a small number of kits to facilitate the sort of introduction and the feasibility, to look at the feasibility and the verification of the test. As you mentioned, Cheryl, we need to make sure that people can use the test, that the option, the test that's chosen is actually working well for the persons who are using it. And that is part of the process. So we've already drafted up a protocol, which is actually has been initially reviewed by PAHO, and we have a second draft that is going to be submitted to both PANCAP, OECS, PAHO, and to work with them to finalize, and then to submit to countries for the ministries of health to approve the piloting. One of the most important things, of course, as you mentioned, is the whole issue of policy. And in order to inform policy, these approved studies in country, small studies, 50 persons really in each country, which will add up to, within the 10 countries, to about 500 persons. The idea is to actually collect the data in terms of looking at how the test works, how acceptable it is to people, triangulating that data, as you mentioned, to see whether in fact there are people who come into the system subsequently, and also to track really alongside the intervention, the assisted testing, which is what we're actually going to do, and to verify that as we go through the process. So that is the next step in terms of putting that proposal forward, discussing it with countries. So there will be discussions with groups of persons in countries that would actually be brought together, including persons from civil society organizations that serve key populations, because these are a key target for this intervention, and the ensuring that we select the organizations that would actually handle distribution, train up the people who would actually be able to support the self-testing in country, so that they would actually be able to support persons who are actually want to conduct self-testing, and that they would actually, we are also working on communication and will be working on communication materials to support the intervention, so that in fact the package of what will actually be necessary will be initially provided to countries and then reviewed based on the experience of the pilot, and based on the pilot create a guideline for countries as they introduce the self-testing within the region, and policy framework that countries can use to add HIV self-testing as an option within their HIV self-testing policies. So that's really what's going to be happening over the next few months in terms of introducing the self-testing in the Caribbean region. Thank you, Sandra.
Yes, thanks a lot. And I must say that there, as Valerie mentioned, there are countries that were selected under the grant, and so those will be the countries that will be initially be targeted and for which the activity, the intervention will be taking place. I would also like at this time to ask one of the key component of doing this is to also look at the data, and the data that will be used to actually monitor programmatically the impact of using the HIV self-test kits. And CARFA under the Global Fund project is also responsible for that key component of data collection. And so Pat is just going to speak briefly, and while she is doing so, we have a poll that will, very short poll, 3 questions I think, that we would ask if you could just respond to, so that which will be able to actually guide the next steps going forward. So Patricia, feel free to go ahead.
Thank you, Sandra. And also thank you, Cheryl, for an excellent presentation. I hope everyone can hear me clearly. You can hear me?
Yes, yes, so we're hearing you.
Okay, great, thanks. So in regards to next steps, I just want to share that the Caribbean Public Health Agency is also providing support to strengthen strategic information under the regional PANCAP CVC COIN Global Fund project. I think the discussion in regards to strategic information, data collection, and monitoring has already started, which is a good thing. And Cheryl has provided some excellent guidance in regards to strategic information, including the reference guide from PAHO, which is the framework for monitoring HIV/STI services for key populations in both Latin America and the Caribbean. I just want to add to the discussion in regards to strategic information, as a reminder, the critical importance of strategic information in regards to providing evidence on services, in regards to access, coverage, quality, and acceptability. It also helps to provide evidence for policymakers, program directors, and line managers to make informed decisions to improve the program. As some countries are moving and considering moving towards implementing HIV self-testing, some data that would be important and some were already referenced in the discussion at the country level to analyze the accessibility, both accessibility, usage, and the impact of HIV self-testing include the distribution of HIV self-testing kits. And looking at several disaggregations, be it by demographic, key population, service delivery points, if persons are accessing it for use by themselves, by partners or others. If we could look at also age and sex disaggregation, and also if the self-testing kits are directly assisted, the testing are directly assisted or unassisted, including a few other data points that we would like to look at. At the country level, I know that the national programs have the main responsibility in regards to the strategic information, but I just want to put in a point there and to put in a reminder of the critical role of civil society and NGOs in this process. As we know, they contribute tremendously to the prevention, treatment, and care services. And they will have a critical role to play in HIV self-testing for key populations. And it's very important to ensure that civil society data is integrated into the national information systems, as this will lead to a deeper understanding of the epidemic and our response, and will also help to demonstrate the added value of civil society in regards to sustainability of HIV services for key populations and at the national level. Thank you.
Thanks very much, Patricia, for that information as it relates to the data collection. The poll I know is on the screen, and so we just ask for you to complete the poll, and so that we will be able to advance accordingly. I want to actually take this time to once again thanks Cheryl for the excellent presentation. Thanks to all who actually participated. I'm sure you have agreed with me that it was a very interesting training, and I think what we need to walk away is the fact that HIV self-testing should be planned and implemented within a strategic manner, and that the result is not definitive, but it should be linked to the national testing algorithm for the country. We have had various experiences and good practice, best practices that were shared, which I am sure will be able to actually provide guidance and as we go forward. I also would like to share that the recording for this session will be circulated. So I'm certain most of us will find it very useful to review the presentation, as well as to emphasize that the learning tools that were shared by Cheryl and the PAHO Virtual Learning Campus, which has additional training materials on HIV self-testing. They are very simple and would not demand too much of your personal time in actually doing the self-learning for HIV self-testing. I want to say thanks again to everyone. Thanks, Cheryl. And we are going to have another session, and I can't remember the date at this point in time, but it will be circulated, and it will actually look at the actual implementation of, for the lack of a better word now, piloting of the feasibility and the verification of the HIV self-testing in the countries for which were actually prioritized under the Global Fund grant. So thank you very much. Thanks for staying with us for the entire process. And we will be sharing the presentation as well as the link with the recording. Thank you very much. Have a wonderful day.